I'm Ashley.
I'm Connor,
And I'm Shay.
and we're here to talk about dysautonomia. Dysautonomia is a group of conditions that relates to the function of the autonomic nervous system. This means that all of the conditions will be related to body systems innervated by the autonomic nervous system. These include the heart,
Breathing. Take a couple deep breaths for me.
blood pressure,
Body temperature. Digestion.
hormonal function, sexual functions, urinary system.
Oh no!
Let's look at some of the subtypes of dysautonomia.
First up is Neurocardiogenic Syncope, or NCS. This is the most prevalent form of dysautonomia and, as you can guess, causes syncopal episodes. These episodes of fainting can happen once or twice in a lifetime or multiple times a day. This type of dysautonomia is also called situational syncope or vasovagal syncope. Postural orthostatic tachycardia syndrome, or POTS, is a problem with blood circulation. This causes the heart to beat too fast when standing up, which can lead to syncope episodes and chest pain similar to what is experienced with an MI or angina, or shortness of breath.
Familial dysautonomia, or FD, is an inherited form of dysautonomia which can cause decreased pain sensitivity, inability to form tears, and trouble regulating temperature homeostasis. This genetic link has been most commonly found in Ashkenazi Jewish heritage and Eastern European heritage.
Multiple system atrophy, acronymed MSA, is the most dangerous form of dysautonomia, as it can be life-threatening and causes multiple system atrophy to develop in people over 40 years of age. This can cause heart rate issues, low blood pressure, erectile dysfunction, and loss of bladder control.
Pure autonomic failure is a form of dysautonomia which causes a fall in blood pressure upon standing, which causes symptoms such as dizziness, fainting, visual problems, chest pain, and tiredness. These symptoms, however, can often be relieved by lying down or sitting. That covers the background needed to understand dysautonomia. I'll pass it over to Shay now, as she breaks down the etiology.
As mentioned before, dysautonomia is a dysfunction of the autonomic nervous system. This is because the nerves are not communicating as they should. When this occurs, and the autonomic nervous system does not send or receive messages properly, it causes a variety of different symptoms and conditions. These symptoms and conditions form due to dysautonomia, but can also result from other diseases. In these cases, we consider it to be secondary dysautonomia. This is the difference between primary and secondary dysautonomia, as primary occurs without any previous relation to other diseases. It is fully inherited, whereas secondary comes from a condition or injury rather than a disease.
This information shows us that the etiology of dysautonomia is not so simple as saying some people are bound to get it while others aren't. It shows us that almost anyone can be victim to the disease, whether they develop primary dysautonomia at birth or secondarily through illnesses such as diabetes, Parkinson's, or something else in the long list of neurodeficit-causing illnesses.
We see this happen worldwide as more than 7 million people are affected by it, as it ranges from mild to severe, becoming life-threatening, with the disease being non-discriminating. It affects men and women equally and can develop from birth or from developing suddenly at any age. Sadly, this disease is still majorly misconstrued, and the exact etiology is not fully discovered. This also means we have little treatment, as you will hear from Ash in the pathophysiology, and treatment is largely symptom-based. Yes, dysautonomia is still vaguely understood, but we do know some of the pathophysiology of the disease. We just don't know how or why it affects certain areas, which makes it very difficult to treat. In general terms, dysautonomia results due to malformation, denervation, or downregulation of the nerves involved in the ANS. However, each subtype is slightly different and can affect different areas of the body. In the case of familial dysautonomia, a mutation in the recessive gene IKB-KAP occurs, affecting the development and survival of unmyelinated small diameter axons that help maintain autonomic and sensory function.
For the next two types of dysautonomia, it is important to understand that around 500 milliliters of blood is instantly displaced from the thorax to the lower half of the body, as well as a 10 to 15% fluid shift of plasma from the vascular to the interstitial space upon standing. This shift will be felt by the baroreceptors, which in response will initiate vasoconstriction and a slight increase in heart rate.
In neurocardiogenic syncope, the dysfunction results in an unresponsive blood vessels despite sufficient stimulation. The failure of the ANS results in the loss of compensatory mechanisms utilized with standing, resulting in an inappropriate reflex blood pressure and heart rate. This leads to a reduction in cerebral perfusion, causing a syncopal episode. In POTS, the autonomic failure is seen as an increase in heart rate for more than 30 beats per minute within 2 to 5 to 10 minutes of standing. Although the exact mechanism of the compensatory failure is not completely understood, there are several ideas as to what is occurring. One theory suggests it could be the result of increased sinus node automaticity. Another suggests a hypersensitivity to beta-adrenergic stimulation is occurring, or a decrease in parasympathetic activity. Lastly, patchy denervation of the sympathetic innervation to the blood vessels can also occur, causing venous pooling in the legs. The venous pooling will trigger and send signals to the medulla in an attempt to vasoconstrict. However, the overflow of catecholamines are not able to stimulate the vessels and instead overflow to the heart, inducing tachycardia.
In pure autonomic failure, peripheral degenerative disorder of the ANS leads to impaired catecholamine production. Postganglionic degeneration is also evident, causing deficits in vasomotor response and sweat production.
In multisystem atrophy, widespread autonomic nerve damage occurs, causing Parkinson-like symptoms. Within the process, astrocytes proliferate, causing scarring within the affected areas, and an accumulation of GCIs, known as alpha-synuclein protein clumps, develop, which have toxic effects on the brain, which is also seen in patients with Parkinson's.
Additionally, stratonigrel degeneration occurs within the brain, disrupting the communication between nerve cells associated with balance and movement. Lastly, olive-pontocerebellar atrophy occurs, affecting the medulla, pons, cerebrum, spinal cord, and cerebellum, which are structures utilized in relaying messages regarding balance and posture, coordination, and voluntary movement.
The signs and symptoms of dysautonomia are different for each form of the disease. However, they do share some common symptoms. Orthostatic hypertension preceded with dizziness or lightheadedness, blurred or tunneled vision, orthostatic intolerance, nausea and vomiting, balance problems, dysregulated body temperature, muscle weakness, fatigue, dehydration, often associated with excessive sweating, sleeping problems, including REM sleep behavior disorder. People normally do not move during this period of sleep, but patients with dysautonomia may move or act out in dreams, increasing risk of self-injury. Bladder and bowel dysfunction resulting in increased frequency, incontinence, constipation, or erectile dysfunction, gastroesophageal reflux, and brain fog or forgetfulness. Other than the common symptoms, we can begin to suspect the different forms of dysautonomia by looking at the symptoms specific to each type. Familial dysautonomia includes symptoms such as
absent lacrimation despite crying. They'll often have feeding difficulties, which subsequently increase the risk of aspiration. They'll have joint abnormalities, altered response to respiratory infection, and something called a dysautonomic crisis, which is severe nausea and vomiting associated with agitation, hypertension, tachycardia, flushing and excessive sweating, salivation, reduced blinking, and it's triggered by an emotional or physical stress or arousal from sleep.
Neurocardiogenic syncope has signs and symptoms that include transient loss of consciousness from lack of cerebral perfusion, tachycardia, or bradycardia. POTS signs and symptoms include shortness of breath, headache, palpitations, chest pain from electrical changes in the heart, syncope, extreme fatigue with activities of daily living, severe tachycardia within 10 minutes after standing.
The signs and symptoms of pure autonomic failure are supine hypertension, patient becoming hypertensive upon laying down due to impaired baroreflex, headache, mild generalized bradykinesia, and reduced blinking.
Symptoms of multisystem atrophy are similar to Parkinson's disease. Patients will have progressive loss of motor function, weakness predominantly in their legs, the inability to sweat, irregular heart rhythms, Raynaud's phenomenon, and supine hypertension.
Treatment for dysautonomia is aimed towards symptom control, as it is an incurable disorder. Common treatments include drinking more water daily to keep body fluid volumes up in an attempt to maintain blood pressures, adding extra salt to the diet to maintain fluid volume in the body and provide electrolytes, sleeping with the head elevated above the body, and medication to maintain blood pressures are also sometimes prescribed.
EMS link for dysautonomia is it cannot be diagnosed in the field as it requires special equipment. However, it is still important to be aware of since many patients will note it as being a part of their medical history. Our treatment for dysautonomia is in an ambulance will be mostly related to symptom relief.
Some of the treatments provided at our level of care are salines to provide electrolytes and rehydration in order to reduce the lower blood pressures experienced and change chance of syncope.
It will also likely be more comfortable to transfer patients in a laying down or semi-Fowler's position with something to raise the head, as it is usually best for the patients to rest with the head above the body.
Thank you for listening to our presentation on dysautonomia.